Okay, thank you everyone for joining. Really appreciate everyone coming out for this. Just going to start with some mechanics things. I'm going to start by going through some background on COVID-19 diagnostic testing. For that portion, I'm going to leave everyone muted. If you want, what you can do is if you click participants, you'll see a window open up with a list of everyone in the chat. You can then click on the raise hand button and that will let me know you have a question. I'm going to try and pause at various points to take questions. The other thing you can do is click on more on your Zoom control and open the chat dialog. That opens a group chat where you can also type questions that I'm looking at and will try and respond to as well. All right, well, thank you everyone. I hope everyone is staying safe and healthy at home. I thought this would be a good opportunity just to discuss what we've been doing for COVID-19 testing and some of the challenges we're having. And then what I really want to do is at the end, open this up more to a group chat format where we can, get some ideas on one of the acute shortages we're facing. Okay, so just a little about me. I think probably most everyone on the call knows I'm one of the clinical fellows in the building, but for my clinical practice, I actually practice as a diagnostic molecular pathologist. And I give a lecture actually on molecular techniques that are used in microbiology for the pathology residents. And I've been on service since last Saturday at the Brigham and Women's Hospital this week, covering that service, including our new COVID-19 assay. And we're seeing a problem brewing in testing that I really wanted to get everyone's input on. So I'm going to start just with some background on the testing, the current state of testing at Mass General and Brigham, and one of the real limitations to hitting scalable testing, and then, like I said, open it up for chat. Okay. So why is this disease such a dangerous pandemic? I think probably many of you know a lot of this from news reports or from other reading, but just to review it so we're all on the same page, there can be a very long carrier period where people are either minimally symptomatic or asymptomatic. There's a huge range in severity here. And then one of the problems is severe infections can require intubation or take up to 6 weeks to resolve. So you can have patients that go onto a ventilator and then actually get better after that period of time, meaning we really need to make an effort to try and save those people. So this is data out of the first 40-some thousand cases out of China, where actually this is what I think has been cited a lot in the news, where approximately 80% of patients have relatively mild symptoms or pneumonia. Note this can still include fever and very debilitating symptoms, but actually there's a huge chunk of patients that get much more critical symptoms. So severe cases, which can include frank respiratory symptoms, and then critical cases where you have evidence of end organ dysfunction and in fact require intubation. And so, there's this estimate of the overall mortality, but I think we don't really have a great sense of what the overall mortality is. One of the other very, very difficult things about this disease is that we're observing that patients can go downhill very, very fast. So you can have patients that you would put in the mild category or in the moderate category, and that in fact within hours actually can tip over and require intubation or ICU level care. Just for comparison with other severe respiratory illnesses, when a patient is developing acute respiratory distress syndrome or something like that, typically that progresses over days. You can see evidence of it coming and you can plan for it. But here, really, a lot of patients go downhill very fast and they can go from sort of mild to critical disease very quickly. On the other hand, you can see that patients who are critical often also do get better and continue on a pathway to recovery. So that's also tough in the sense that it means we want to make every effort possible to grab as many of these people and save them, even if they require long-term intubation, just because there's a solid chance that they will ultimately recover. Really, the clinical phenotype of this disease is so variable, which has been one of its challenges. I won't talk about this too much because it's been all over the news, but this really is what prompts the strategy of so-called flattening the curve, or essentially trying to spread out infections throughout the time course of the disease. And so the idea is there's a certain fixed amount of cases that we can take care of in the healthcare system. I think we can think of this basically in this particular disease. A good proxy for this is just the number of ventilators in the country. And in fact, if everyone got the disease all at once, we would run out of ventilators and healthcare capacity. But in fact, if we can spread it out and spread out the number of cases and ideally keep the total number of cases down, obviously, hopefully, we'll get the best possible outcomes. This was just a nifty little graphic I saw on the internet that I pulled about social distancing and why it's important. Here you can see exponential growth of cases, or as an alternative strategy, if we start obviously taking the dramatic measures that we've been taking, the idea is to reduce the n number of cases here on this side. And so, hopefully this is the logic in mind, I think, where institutions like MIT and others have, decided to essentially send us all home. Okay, so I want to turn now to diagnostic testing, the ostensible name of this presentation, and just some background on diagnostic testing, just so we're all coming from the same framework. There are actually two totally different regimes of testing in the United States. There are commercially developed tests, which are made by manufacturers and require full studies and licensing from the FDA. And basically, these are tests that are going to be marketed from one developing lab to another as in vitro diagnostic devices. Essentially, they're sold. There's a long and costly process for approval typically for commercially developed tests, with one exception, which is emergency use authorizations in a declared health emergency. The second type of tests are laboratory developed tests. So these are regulated under a particular amendment in one of the laws that was passed that actually allows individual labs to develop tests themselves for their own internal use without being allowed to sell those tests to other laboratories. The reason this was useful is for something like Lyme disease. Obviously, we get a lot of Lyme disease in New England, but there's not enough cases of it and not enough cases nationally where it makes sense to do a long and costly study to approve a test for Lyme disease. So this exemption exists to allow places like Mass General and Brigham and Women's Hospital to test for rare or more specific things where there might not be a distinct commercial interest. That's been extended to develop a lot of other kinds of tests, for example, for cancer sequencing panels, where we might also not do a long and costly process, but where we can test and basically validate things. These tests still have to show efficacy, you still have to validate them, but typically they're only reviewed on a biennial basis. Now there is one exception to this, and that exception is actually in a declared health emergency. Actually, you're not allowed to develop laboratory developed tests. In fact, you have to have commercially developed tests, and everything has to be submitted to the FDA for approval under this emergency use authorization process. And I think this has been one of the things that has caused a little bit of a delay in testing here in the United States. Okay, so just a brief rundown of that testing history. We knew by the end of December, China notified the World Health Organization of pneumonia cases of unknown origin. The genome of the virus was actually produced very quickly. And actually on the same day, the first case landed in the United States and in South Korea. So the first case in the US was confirmed by the CDC. And at this point, only the CDC main lab in Atlanta was running a test. There's a German group that developed an initial RT-PCR assay for what was then called 2019 nCoV, now of course called SARS-CoV-2, causing the disease COVID-19. And then by the end of January, the Health and Human Services Secretary, Dr. Azar, declared a public health emergency. So this is good in that it speeds up the process for vaccines and treatment, but paradoxically increases the requirements for testing in that it doesn't allow lab-developed tests. So academic labs like ours were actually issued notice to stop any development on tests in-house and to file instead an emergency use authorization with the FDA. So on February 4th, the FDA authorized the CDC's EUA to be used at any CDC lab. So this includes about 100 public health entities around the country. the CDC, for reasons that are somewhat unclear, was not using the same assay as the World Health Organization, but had developed its own that attempted to distinguish SARS-CoV-2, the virus causing COVID-19, from the earlier SARS virus and the Middle East respiratory syncytial virus. Unfortunately, there was a faulty primer set in the CDC assay that gave false positives. Later on, the CDC notified the FDA that there was a faulty reagent, and that unfortunately caused a process where all tests now had to be done at the central CDC lab in Atlanta. So eventually, the partner labs requested permission to start running their own tests. They were initially denied, and at this time, there were already about 50 confirmed cases of COVID-19 in the US. So eventually, FDA issued a single emergency use authorization to develop similar RT-PCR tests to the CDC test, but however, this was only reserved for the highest complexity labs and had to be using specific machines and specific reagents. This might be why some of you might recall we got all of these emails that the clinical labs were looking for very particular machines and very particular sort of cyber green and other reagents. The reason for that was that it was actually very specific things that are validated and were allowed. So the guidance now on March 6th changed even further, which was that now laboratories could develop their own tests and file an EUA, but they could use the test in the meantime while the EUA was pending for up to 14 days. So March 6th is really, in some ways, the go date of clinical testing in the United States. And the guidelines were that the test should be sensitive down to 5 viral copies per microliter, and you should be able to detect 5 positive samples and 5 negative samples and have that internal validation in your lab before using the test. There's still a problem there, which is most labs didn't have access to 5 positive samples. There was lots of questions about whether we could use synthetic RNAs, et cetera, and unfortunately it was a little bit unclear. So in parallel to this is, of course, when social distancing measures started, and for us, principally, MIT began to scale back operations, including, essentially making the rest of term virtual. And then now in March is really when things have started to ramp up. The first emergency use authorization was issued on March 12th to an outside lab, which was to Roche, and they begin to scale production. So now we're hoping and we're starting to see the effects of this kind of expansion of testing. But I mention all of this just to give you a sense of kind of what was going on when we already knew that this disease was brewing earlier this year. Okay, so this is the SARS-CoV-2 genome from the German group paper that initially identified it in January. And here we're comparing the CoV-2 strain to the sequence they had for SARS-CoV, which was the original SARS respiratory virus. And this is the World Health Organization assay designs primers against these 3 regions. And here what you're seeing are 6 isolates of CoV-2 that they had from Wuhan, China, versus human SARS-1, they had a Frankfurt strain, and 2 bat-related SARS viruses. So this is also where the inference started emerging that maybe this was a virus that had jumped from bats to people. And so what I hope you can appreciate is across these regions, there's not actually a lot of polymorphisms that distinguish SARS-CoV-1 from SARS-CoV-2. And so this is where the CDC got focused on finding something perhaps a little bit better or a little different than this assay for the United States. In fact, the CDC assay uses 3 primer sets, all in the nucleocapsid region, that has a little bit more polymorphisms between CoV-1 and CoV-2. But as I mentioned, unfortunately, one of those primer sets was faulty, and it took a couple weeks to realize that and reissue guidance that we could count the test or score the test even with 2 out of 3 primer sets. Okay, so as I mentioned, South Korea had a very different course with this disease for a number of reasons. So one, they were actually able to scale testing very, very quickly. What had happened was when the MERS coronavirus first came around a few years ago, actually South Korea had a fairly significant scare with that, where they had, I think something like 17 or 18,000 cases with, less than 100 deaths, something like 20 or 30 deaths. But that basically alerted their health system to the need to be aggressive and test immediately up front and to have mechanisms in place to do that. And so I think they were able to sort of aggressively test, contain patients, and presumably their outbreak is under a little bit better control than some of the other countries around the world. This impacts mortality quite a bit. So if you look at world mortality for COVID-19 going back, of course, in the initial pandemic days, mortality was driven almost entirely by the outbreak in China. But as that subsided, now in the Western world, we see potentially mortality rates rising. South Korea never quite experienced an outbreak. Now, they also had some advantages that we don't have anymore, which will be the focus of the end of this talk, which was basically at that time, there was no declared pandemic. And so what that means is they're able to get all the supplies they need. There's no shortages. And so that really enables testing and enables them to move forward in a way that we unfortunately don't have the luxury for that anymore. Okay, so just a word on the clinical laboratory. Basically, in the clinical laboratory, you want as limited hands-on time as possible. Specimens are continually coming in. There's a lot of specimens. You have to process them quickly. There are regulatory requirements, even in these situations, we still have to adhere to, which is that there's a documented chain of custody for every patient sample, meaning from the moment the sample left the patient, it's documented where that sample is, if it's in transport with whom, when it arrives to the clinical lab, when it begins testing till results go out. Everything has to have 2 unique patient identifiers that can be linked back to the patient. Typically, that's a name and medical record number. The clinical lab, we have to interface with the hospital laboratory information systems to allow test ordering, sample accessioning, and result input into the medical chart. And obviously, we have to perform validation studies demonstrating that our tests work. So there are 2 broad ways to think about assays in the clinical labs. The first is that basically you get a sample, you input the sample directly into a machine which generates a result and results it out into the medical record for clinicians. The second type of test, which is a little bit more laborious for laboratory, is that you have a sample, you need some processing into an assay that you yourself run, and from that assay, you result the test, either by a pathologist like myself, signing out the test and entering a report into the medical record, or by some more automated method. Now, the CDC test is an RT-PCR test. I know most of you are probably familiar with that technology, but essentially it was designed to run as a sample to assay to result test as well, following an extraction of the specimen. There's no automated machine that runs a one-off CDC test. Okay, so I want to go through some of these tests that have been in the news recently, just to put them in context for what we're doing. So you may have heard over the last couple of days the approval of a 45-minute turnaround test for COVID-19. So this is the Cepheid system, and this is a sample to result test. Basically, you have these gene expert cartridges where you can pipette out literally the nasal aspirate contents, and this cartridge is itself a series of processing chambers that essentially contain a mixture of reagents, primers, probes, and buffers that can process the specimen through. There's a thin amplification wall here that allows for a rapid thermal cycling and a series of valves internal to the structure that control it, and that can basically control flow through it that comes from the machine you put this in to generate your RT-PCR reaction. So this system was initially developed for influenza testing in the emergency department setting. Patient comes into the emergency room, they have flu or they don't have flu. You need to know relatively quickly as a hospital system to determine bed placement, contact precautions, that kind of thing. Okay, so it truly is a quick test, but there's a catch. You have to have one of these gene expert machines that can process the cartridges. So it's true, and you'll see in the news that there are about 5,000 of these machines in the US, but they range in size from the Cepheid Infinity, which can handle hundreds of samples at once, although again, a lot of these are being used for influenza testing, to some of these point of care gene experts, which can really only take 1 or 2 samples. Just to give you a sense of scale, that's the same cartridge that's sitting here on the countertop of the Infinity machine. So there are about 5,000 machines. We don't know exactly what the breakdown is. The company hasn't told us exactly what they've sold. And these cartridges are potentially coming. They were just FDA approved under an EUA. But I can tell you we haven't received any yet at partners, although we're told they're hopefully coming by the end of the week. Okay, the other big diagnostic machine and category that we have is the Roche machine, the Roche Cobas machine, which, as I mentioned, was one of the first EUA's, emergency use authorizations issued by the FDA. Now, Roche is something of the 500-pound gorilla of diagnostic pathology in that they have huge market penetration with all of their machines. They're widely distributed across the country. So Roche says they will ship 400,000 tests this week alone. Now, the Cobas machine itself, there's somewhere between 100 and 200 of these. It comes in two flavors, the 6600 and the 8800, and they have very different throughputs. It's about an 8-hour turnaround time when you load the batch, but it is also sample to test. In other words, aspirate goes in, the cartridge is loaded into the machine, and the machine automatically can separate all of these samples based into the tests that were ordered, based on interfacing with the laboratory information system straight from Epic and resulting straight back to Epic. So this is a nice all-in-one solution for community hospitals or places that maybe don't have as much medtech support and for reference labs. So I think this really could help quite a bit. It's unclear, even if we ship 400,000 tests, if we have enough of these machines up and running to process that many tests per week. But it has the potential to scale, and I know a bunch of places are trying to get their hands on more of these Cobas machines. Okay, so certain testing centers have also been in the news. Basically, Mayo was in the news that they're now processing 4,000 tests a day and able to cover almost the entire state of Minnesota. That turns out to be the good luck of having 3 of these high throughput Roche Cobas machines on site that can basically process and churn these tests. Mayo Clinic is also a large reference center in the diagnostic pathology world for all kinds of testing. The real workhorse in the community, though, out in more rural settings, places that don't have Mass General and Brigham and Women's and places like that down the street, for better or worse, in American healthcare is Quest Diagnostics and Laboratory Corporation of America. These are huge reference labs that basically are able to collect samples from rural hospitals, reallocate them to their sort of main testing centers quickly, and process tests. So essentially, both have Roche Cobas machines, and both have been issued EUAs for their own internally developed RT-PCR tests now. Quest claims they'll be at 25,000 tests per day by the end of the month. LabCorp is doing 20,000 tests per day at present. But note, the sample has to be collected, make its way to a reference center, and the result then sent back and communicated back to the ordering clinician. And one Quest or LabCorp center is probably working with hundreds of hospitals or doctors' offices. So this is where we get into this 3 to 5 day turnaround time, especially if a lot of the volume is coming at once. So if you're seeing stories about, frustrated patients, well, I think all of us across the medical spectrum share some frustration about, the delays here. This is part of where it's coming from. At the end of the day, it's still an RT-PCR test, but it has to go through these kind of specimen steps until we really get to point of care testing. Okay, so all of that being said, what's going on right now in the partners hospitals where I'm at, and why I sort of bring this up? So at Brigham and Women's Hospital, we've validated our own in-house RT-PCR test according to the appropriate machines. We have all of our RT-PCR machines in the lab, and that we were able to get donated from research labs running, and basically all of our techs are doing this. Even still, if you think about an RT-PCR machine, there's only so many samples that fit on a 96-well plate. We have to have replicates, we have to have controls. All of that validation has to take place to know that it went well. We can only run 21 or 22 patients on a plate. So running round the clock with our techs basically coming in at 6 a.m. and working till midnight, and of course in separated shifts, because some of these are positive patient samples and we want to avoid getting our med techs sick. because that would be catastrophic. We're hitting about 198 tests per day on the weekday and 132 per day on the weekend. The RNA isolation itself, again, is by essentially QIAGEN kits, these viral amplification or isolation rather kits from QIAGEN, whatever we can get our hands on. So you can imagine supply gets limiting very quickly. And this is why we're constantly seeing these emails in the research labs, do you have these kits with these catalog numbers? Literally, we're doing this on an ad hoc basis, trying to get as many kits as we can. Obviously, these are back-ordered. QIAMP itself and the QIAMP system from QIAGEN, basically everyone in the country, including LabCorp and Quest, all wanted these at the same time. They're, of course, trying to scale production what they can, but it's unclear if they're going to be able to meet the need, particularly if the need continues to skyrocket. So right now, we have what we think is about 10 days worth of isolation kits for isolating samples from a nasal swab left. And constantly, we're calling every day to try and find people who have these, can manufacture them, can use them. And right now, these kits seem to be the limiting reagent. Okay, so Massachusetts General Hospital has a four-pronged approach, and actually Partners Healthcare is actually doing a reasonable job of coordinating response between these hospitals. So some of these MGH tests are actually from Brigham ambulatory clinics, et cetera. So the idea is to have a one-stop coordinated effort in terms of procuring reagents and sharing reagents. Basically, we also at MGH have an in-house RT-PCR test that launched just last week. There is one of these Cobas machines there. We have some Cobas cartridges. We have one of the Cepheid Infinity machines, but as I said, we don't have any of the actual processing cartridges yet. And so we're running a few Cobas tests. They're sent out to Quest Diagnostics, which itself has a Cobas or its in-house RT-PCR assay, and then send out to the Mass State Lab. Altogether, all of this volume is about 400 tests per day, and currently reagents for the in-house test are at about 2,000 remaining RT-PCR reactions, which is also about 10 days of supply. What happens at the end of 10 days if things are still backordered and we can't get things? That is the kind of thing that is quite scary to think about. So just to give you a sense of that, if you think about that, 400 tests per day at MGH and 100 to, let's say, 200 tests per day at the Brigham, that is not even quite enough to cover all the patients coming into the emergency department with cough and fever, right? I mean, basically, this is why the tests are being triaged to known exposures or the highest risk patients, or even ED patients with symptoms who are getting admitted, is essentially who is being tested now. And I know that obviously is not good from a public health perspective in terms of managing outpatients and people might be at home, but this is where we're at the moment. Okay, so all of this is to say I've actually only covered even just one diagnostic sliver of the diagnostic spectrum of COVID-19. There are additional ways to think about diagnostics. Obviously, point-of-care devices or at-home diagnostics, people are working on developing those. You can think about serology testing for antibodies indicating that a person has been exposed. So that's obviously another way to think about detecting COVID-19. There are efforts to detect the viral antigen. So one way for influenza that we often detected is patient sputum is smeared on a slide, and you can add a reagent that's essentially a fluorescent antibody, look quickly under the microscope and see if antigens are bound. Now, I don't know if that would be sensitive enough. All of these techniques at this point, since we're still in a declared health emergency, have to go through the FDA with an emergency use authorization. If you're interested, there's a list of the tests and validation status here at this website that it seems to be a somewhat comprehensive list of things that are going on. I know there are efforts, in our community and across the research community to contribute to a lot of these diagnostics, and I can't tell you how deeply that is appreciated in the pathology community as we all just run around trying to load our next RT-PCR plate. Okay, so reagents and extraction kits are rapidly becoming limiting. Supplies are, being depleted, and the need is ramping up. And part of why that is happening, and this is the one BS not well supported slide in this presentation, I have to say, it's somewhat rumor and conjecture, but there are groups that are now assembling this information as well. What's happening as this pandemic goes globally is that, folks are often looking to their own borders and either have explicit or de facto export ban on some of these components. So part of why I'm also bringing this up is even though we do have 10 days worth of kits to sustain testing right now at the level we're doing it at partners hospitals, what if in the future we lose all access to those kits just because, something like 80% of all the sheet polypropylene plastic in the world is manufactured, in Asia, and if that's export blocked and we can't get that here, it's unclear if suppliers will still be able to make components. Okay, so before we go into discussion for this, I wanted to first just briefly mention what the actual specimen we're talking about here is. These are nasal swabs, so this is the specimen with the highest sensitivity. Some laboratories are also accepting oropharynx swabs, which just imagine this probe is instead going through the mouth, but the goal is still to hit the back of the oropharynx. And so you get secretions in there, think mucus and think of sick people mucus, epithelial cells and granulocytes, and hopefully additionally shed viral RNA or RNA contained within infected cells. So that's the specimen. Typically these swabs are, these applicators, they're broken off, and then this portion comes to the lab in media, which is essentially a lot like PBS. And in fact, some labs now, because testing sites are running out of viral transport media, are actually accepting these kind of applicator sticks broken off in sterile PBS. Okay, so this is the problem. Assuming that we lose supply chain and assuming we can't get these kits that take out viral RNA, how can we get high yield RNA from these specimens without using potentially supply limited reagents? And the first thing I would say is, of course, some folks have tried this. So what this is obviously this is an RT-PCR cycle curve. And so I know most people are familiar with the assay, but just to remind everyone, to the left means there was more virus or more detection because there's amplification occurring at an earlier cycle number. CDC guidelines currently are suggesting that nothing beyond cycle 40 be interpreted. For those of us who have done this assay, that's probably quite reasonable. And so if you isolate your nasal swab with the QIAMP viral RNA mini kit, obviously you get very nice amplification. Now, if you take that same specimen and you just take the saline or something from it with no RNA extraction, you still can get an amplification, but in fact, you have somewhere between 18 to 30-fold reduction, depending on how you count the equivalence between no extraction kit and with the extraction kit. Heating it, at least for this paper, didn't seem to actually make too much of a difference. You're sort of still right here on the curve. And this group also tested synthetic spike-in RNAs of the viral RNA. So really the question is, how do we close this gap in an emergency or in another way we could think of where we could get RNA out of these specimens in a high throughput way, amenable to medtech input without potentially using limiting components, assuming this continues to still be the limitation. I would love nothing more than for this talk to be irrelevant in 2 or 3 weeks because Cepheid and Roche and other commercial manufacturers have completely filled this gap and there isn't a problem. That would be fantastic. This is just to show you also from that paper, the other QIAGEN RNA extraction kits do work, but they're at 2 to 4-fold loss. That's probably not that bad. And it's something of an open question. We don't really have any guidance as to whether the FDA will accept an emergency use authorization if we're at 2 or 4-fold lower sensitivity than the gold standard extraction method. It's somewhat uncharted times for everyone. Okay, so with that, I just want to restate the question. The problem is how we get high yield RNA from these specimens without using kits. And is there anything anyone in the audience can think of that would be better than potentially just boiling nasal swab and, aliquoting 10 microliters into the RT-PCR reaction mix?